Good afternoon, everyone. I'm Dr. Jessica Parr. I'm a CU Alumni Association board member and a graduate of the class of 2016, and now I'm a cardiologist. Thank you for joining us for the Housestaff Professional Development Series. This series was created in response to input from our house staff regarding a need for information about professional development, and the CU Alumni, CU Alumni Relations Office, the CU Medical Alumni Association, and the Housestaff Association all partnered together to help address this need, and we are honored to be involved. I'd love to thank Dr. Muru and Dr. Stump, who are the co-presidents of the Housestaff Association, the members of the association, as well as Sally Robin for their work on this series. And for all of you joining us today, whether you graduated from medical school at the University of Colorado or are here completing your residency, each of you are part of our alumni family. The Housestaff Professional Development Series is just one way we're here to support you, and I encourage you to reach out to Noel Rodriguez, our Alumni Relations Specialist, and the CU Medical Alumni Association about other resources and events that are available to you to help you with your careers. Now I would like to introduce our speaker, Jon Appino, who's the founder of Contract Diagnostics. After receiving his bachelor's with a pre-med focus, Jon decided to pursue a career in business instead of medicine and spent the next 12 years working in multiple roles in both large scale and startup pharmaceutical and biotech companies. He completed his MBA in 2006, and 5 years later, he launched Contract Diagnostics. His passion to educate physicians about the non-clinical aspects of medicine is evident in the focus of his work. And Contract Diagnostics is the only firm in the country with a 100% commitment to assist physicians in understanding and negotiating their employment agreements and compensation structures. To date, they have reviewed nearly 10,000 physician contracts. So please join me in welcoming Jon Appino. Thanks, Jon.
Hey. Dr. Parr, thank you so much. It's good to be back and giving this presentation. It's changed over the years. I think let me see if I can share my screen here. You guys, can you see everything here? Did it pull up okay? I think so. So yeah, we've been at this for 12 years now. I think the new total is over 12,500 agreements that we've looked at and families that we've helped. So we love doing this. You see the slide, it's me. We do have Dr. Sarnowski on our education staff here. She's not going to join us. She's a practicing OBGYN physician, and she is she's on call today, not too terribly far from the campus, believe it or not. So, so she is working, and I'll be taking care of the call. We have a great team of attorneys and consultants and educators and everything here to help with anything that you guys need. Today, we're going to talk about physician contracts. Understanding, negotiating, and following trends. You'll forgive me if I'm speaking only waving one hand. I was in an accident last week, and I had some surgery, and so my right arm is in a sling. So, so I will be going through the slides. I think I can still advance them with my one good hand. So we'll spend probably 40 minutes or so, 45 minutes going over content. We'll leave as much time as we can for questions. As Dr. Parr said, if you've got questions afterwards, feel free to message, send them in, everything else. This was brought up at the initial introduction. My name is Jon. Dr. Catherine couldn't make it, and we are the only firm that specializes in contracts. We don't sell data, we don't do anything else. And I say this not because this is about us today, but just to kind of set the frame. This is all we do. We've been doing this for over 12 years. We created the market on a national company that can look at physician agreements and coach and guide you all in what to and how to ask for things, knowing that dermatology is much different than endocrinology, is much different than cardiology in Chicago or in Massachusetts or in rural Kansas. So we love talking about this stuff. We love doing education, which is why we have Dr. Sarnowski on staff as not as a marketer or as an attorney or as a reviewer, but as an educator. So we love to do this. If there's anyone in your neck of the woods or a program or association that we can help with education, please do reach out. Today, we'll talk about contract reviews. We'll talk about everything from the initial site visit to the actual negotiation. We'll talk about key sections that are in most physician employment agreements. We'll talk about various compensation structures. We spend a lot of time at Contract Diagnostics talking about compensation and benefits, and we'll make sure that we spend a lot of time today talking about that as well. And we'll, of course, discuss trends, compensation, employment trends, what we see, maybe some predictions if we have time, and we'll leave as much time for Q&A. But it doesn't matter if you're a fellow or a resident coming out of training or if you're an attending. whether you're looking at a new opportunity or you're just revisiting your current contract. If it's automatically renewing, we can talk about how we can negotiate and things that we can maybe potentially change. So if you're in a new contract phase, obviously a site visit is something that is wonderful to have back. I remember back in May and in June and July of 2020, there were no live site visits. Everyone was doing Zoom interviews for jobs. And it was very challenging because you had an anesthesiologist who hadn't been on site. You'd have a clinician that never stepped foot in the actual clinic that they might be working in. And so it was challenging, but now site visits are back. So we think that these are a great time to start evaluating the practice for fit, to start asking lots of questions, maybe even get a letter of intent and set the expectations regarding a timeline. So as we look at the site visit, again, it's nice that we can all go back. You guys can check out the facilities that you're working in, check out the communities that you'll be serving, meet your colleagues, look at the flow of the OR or the flow of the clinic, and kind of get your bearings set. Make sure it has the equipment and the items that you need. We do think this is a great time to start to talk about financials, not necessarily to say, I want X dollar. In fact, if they mention something about salary or compensation on a site visit, we think you should just delay. I think or defray until you actually have something in writing. If they say, what are you seeing in other offers? If they say, what are you looking for compensation? We think it makes sense just to give kind of a blanket statement. You know, guys, I'm sure that the letter of intent or the contract will be competitive with the other offers that I'm seeing. What we don't want is you throw out a number, not knowing what your fair market value is, and it's less than. And they give you what you asked for. And then if we guide you on coaching you for more, or if, you know, maybe you just accept an under market valued offer, it cannot be a good thing. So we encourage you guys to ask a lot of questions and let them know that I'm looking forward to seeing the entire deal, not just a number, because obviously a salary of $250 or a salary of $300, it's hard to tell which one's better because there could be a lot of risk, there could be a lot of reward in one or the other. And just because there's a higher salary doesn't always necessarily mean that that's a better offer. So we think that this is a time to ask a lot of questions. One is to talk about timing. So will I get a letter of intent? Will it go straight to a contract? What's the process? And if you get a letter of intent, these are usually one page. We have seen them much more detailed. But we feel like this is the time to negotiate the things that are on the letter of intent. So if the letter of intent just has compensation, you'll be paid a salary of X. We think that should be negotiated. If it has benefits on there, you'll have a certain amount of time off for CME dollars. If there are signing bonuses or any kind of production bonuses, we think this is the time to negotiate that as well. This is also the time, if you're going to engage a firm, to engage a firm. What we don't like is when a letter of intent is signed, then you get the contract, then you call us and we want to ask for more money. We get pushback from the employer saying, you sign the letter of intent, we assume that you're okay with the compensation numbers. So this is a great time to negotiate the things that are in the letter of intent. If the non-compete's there, I think we should negotiate it. If it's not there, we can negotiate the things that are there, and then we can move forward with the contract. If the non-compete poses an additional risk that we didn't anticipate, then we can go back and ask for more reward or compensation. The question, is it binding, comes up all the time. John, I signed a letter of intent. It's okay that I keep looking at offers, right? Most often the answer is yes. However, we have seen letter of intents that have said, by signing this, you're intended to sign the contract, or you are agreeing that you're not entertaining other offers. So it's important to know what the process looks like and what you're signing from a letter of intent. But most typically, it's like the example we give here. The physician's paid $400,000 per year with a signing bonus of 20, relocation of 10, malpractice included, 4 weeks of vacation, and a start date of August. So again, if it was me, I would look at 400, I would look at 20, at 10,000, at malpractice, at vacation, and a start date as items that I can negotiate today based on my perspective. If we go through sections of the contract, we can talk about expectations and the position, schedule, if you will, talk about compensation, money, malpractice, restrictive covenants, and termination. There's a lot to go over here. And I was talking with Dr. Poir before we hopped on about, I wish that this is like a 3-series part because there's so much content. I feel it could be 3-hour-long sessions and then even a wrap-up session and then a Q&A session. But I know we don't have that time, so we'll do as much as we can in the time we have here, moving quickly. But If we look at the schedule, right, this is something that we see in all contracts. We hope it's very detailed. So it could be in a contract, it could be called your job description, it could be called the services, it could be called duty, it could be called scope of services or the work assignment, it could be under definitions, it could be called lots of different things. But we think that all contracts should be very clear on two portions. One is your schedule or your time, and the other is your compensation or your money and benefits. So if we look at the schedule, these are some of the things that we'll see in there, okay? We might see things like, urgent care may or may not be there, right? I mean, maybe if you're a pediatrician and it doesn't say hours, it just says a minimum 40 hours a week. Well, we don't know if you're working urgent care in the morning or after clinic, if you're working Saturdays, okay? We don't know what the operating hours of the clinic or if they could change. We don't know what locations you'll work at unless it's very clear. So let's make sure that there's certain things in the agreement that are very clearly defined, not minimum 40 hours at a location to be determined by the practice, which is what we see very commonly, but something very specific. You'll work at the practice on 4th Street, additional locations with your permission. You'll work general clinic hours, 8 to 5, Monday through Friday, 36 patient contact hours a week, unless otherwise agreed by the physician. Physician shall take call no more than 10 days a week per month. 10 days per month. Additional calls shall be with permission of the physician. Something very concrete. So you know exactly what their expectations of you are when it comes to your schedule. We think it should be detailed. We think it should be with your approval to change. And if they want to add something on, if they want to change a location, they can come and you get your approval. If you say yes, then they can add an addendum. It's fairly easy for an employer to do. Compensation. We could talk for days and days on compensation, structures, how it's changed over the past 12 plus years. But we'll talk about different structures, salaried, RVU, and collection-based for our time today. If we look at salary, some contracts you just get paid a salary. You have a flat salary, it's X amount, and maybe it's a 95/5 clinical split in an academic center, or maybe you just get paid a flat amount for the first couple of years and then roll on to a compensation plan. So salary only is something that we see sometimes. Obviously, it varies significantly per specialty. If you're a pediatrician working in a private practice, or if you're an employed neurosurgeon, we see a large delta based on what type of work is required in the specialty training of the physician. You can have a salary plus a bonus, or you can be paid a shift or an hourly rate. One thing that we always want to know is, how does it change over time? So let's say that the contract says you'll be paid $250,000 per year. It's a 3-year term. So my question would be, it sounds like it's $250 per year every year, correct? Maybe one thing that we could look at negotiating is having that automatically go up. So 250 to 275 to 300, or 250 to 260 to 265. I want to know what happens after the end of the 3 years. So we want to know how it's changed over time, what the range of these salaries are in the defined department. We have a list of compensation questions that we can send over to Dr. Parr and Noel, and I'll make sure that those are sent over for distribution after our time today. RVU structures are also super popular. So this is something where the employer typically sets a conversion factor. There's a general factor by Medicare, but the employer setting it based on geographic practice cost index, malpractice cost, lots of other various factors go into how an employer could set a conversion factor and how that could be different in different markets and different specialties. But most of the time, there'll be a conversion factor. And we think that it's the time to break out a calculator and do some math. This is fairly simple math, and we'll walk through an example here. We think it's important that you guys should understand the report. So if you're compensated on a production schedule, whether it's compensation per RVU now, or in our next model, it's a collection-based structure, we think it's important that you guys understand the reports that you're going to be given and that you are provided examples of those. So know what those look like. I think it's an important consideration to ask for that before you jump into to sign a contract. Get an example report. They can block out the physician's name, but I want confidence that they can pull the report and transparency that they will. Know the expectations. What do you think I'll do in year 1, 2, and 3 is a question that I would always ask. And what's the range in the department? Is the range 6,000 to 6,400, or is the range 4,000 to 9,000? So a big range, okay? And then of course, understand the needs of the specialty. Some might be very different. You might have a lot of procedural codes for one and not a lot for others. If you're an orthopedist, you may not make a lot for seeing a lot of patients in clinic. but doing procedures is where you get. So obviously having block time is something super important. All right, so an example of an RVU model, the physicians paid a base salary of $400,000 per year and $44 per RVU over a threshold of $10,000, okay? So I can look at this and I look at three levers, all right? So 400 is a lever, okay? We wanna pull it for a higher salary. 44 per RVU, okay, we wanna pull that for a higher RVU rate, or a threshold of 10,000, we wanna pull that and have it be lower, okay? So I think we could do a combination of the two. But immediately when I look at this, I'm thinking to them, look, if $44 is what you can afford to pay me per RVU for 10,000, I should have a salary of $440,000. So I would initially come back, and my easy ask on a contract like this, without knowing all the backstory, would be $40,000 would make more sense for a salary. And then I would ask them to kick it up to $46 over 11,000 RVUs a year. So something, maybe a double tier approach would be something that you could talk to these guys in a situation like this. But again, every situation is different, every employer is different, and every physician's story is different, which is why it's important to have every contract reviewed and to have customized solutions and an approach based on your story and your particular opportunity. Collection models. So we see RVU models oftentimes in hospital employed physicians. We see collection models oftentimes in private practice situations. So they're variable significantly. Ophthalmology and glaucoma is so much different than dermatology, which is even so much different than Mohs surgery, which has a big difference between a general clinician working in a pain practice. So again, same thing. I want to see the reports. I want to know that they're able to pull them, especially in a small practice. I want to know that the reports are accurate. We've talked to far too many physicians who call us after being in a practice for 2 years or for 3 years. And when we've asked them, what's your production? They'll say, I don't know. And we'll say, what do you mean? You're not getting the reports? And they'll say no. Or they'll say, they're always screwing up the reports. I spend 10 hours a month just auditing reports. So again, I want to make sure that the reports are valid, that they're accurate, that you have access to them, and that they're transparent with your numbers. So there's never an issue with what you're producing. What can you control? Are there certain payer mixes? Maybe there's 3 or 4 different offices, and the payer mix is different for each one of them. So which office will you be at? That might matter. Okay, if you're going to be doing a lot of procedures or clinic-based, that might matter. Okay, what are the definitions? There might be definitions on total collections or on profitability, on expenses, both direct and indirect. And it's important to know those definitions. And going back to the prior point, what can we control? So if they're factoring something by a % of overhead, do you have any control over the overhead? Do we get to have a say in how much the Christmas party costs, if that's a factor in your overhead? Are there direct expenses? If so, can we take certain expenses that might be classified by the IRS as legitimate expenses, such as a home office deduction, a home computer, or maybe a higher dollar amount for CME and conferences? So it's all important to understand the definitions in a model like this. Really, really important. And these are very intricate, and they have a lot of little asterisks that can be found throughout the entire thing to make sure that it's calculated and paid fairly. But a simple example would be this. Physicians shall be paid a base salary of $400,000 per year and 30% of net collections over $800,000. Okay, so the salary is $400,000, that's a lever. The $800,000 is a threshold, that's a lever, it could be lower. The 30% is a lever, that could be higher. And net collections, well, that's something that we should definitely define. Okay. And again, this whole thing is fine, but again, it's $400,000 over $800,000. What about proration? What about a partial year? I want to make sure that that $800,000 is prorated. If you work for 6 months and collect $600,000, do you get a bonus? Depending on how they structure it and how it's worded and how they're looking at it, the answer may be no. So let's make sure that although you should, because you received half of the 400, you should have half of the threshold, but it's the threshold that matters. So let's make sure that everything is prorated. And let's also understand termination pay, because that matters in a collection model as well. All right, compensation and value. So we're seeing a lot more of these lately. These could be dependent on the department, or they could be individual, or sometimes a blend. So it might be a physician quality or value. It might be how the department does as a whole. So again, what can you control if it's dependent on the hospital? Sometimes we'll see like a value pay, which is like got a bunch of factors, from quality to the profitability of the center to the group's performance and your individual performance, and each one matches 2% of the salary, and they can be fairly complex. But understand the timeline for these, if they're prorated for a partial year, And they're usually a percent of your salary. They might be a defined amount. A typical example would look like this. You'll have a quality bonus of $30,000 per year based on metrics determined by the employer. Great. I would obviously want to know what the metrics are. I want to know when is it paid. I want to know per year. Is it a contract year, a fiscal year, or is it an academic year? Those could all be different things, or a calendar year. So I would want to know a lot of details on this before I just breeze past a section like this by saying, hey, $30,000, great. I'd have a lot more questions for a section like this. And also on quality, make sure it's not a withhold. So sometimes we'll see withholds. So it'll say, you might see, we saw a contract last week, $67 per RVU, but $5 is withheld for a quality bonus that's paid at the end of the year. So the effective rate was 62, and the physician may or may not receive up to 67 per RVU based on undefined factors. So it's important to know if it's a withhold or if it's an actual bonus. All right, how do you evaluate pay? So we have a tool here called Compensation RX. It's for somebody who doesn't need a full contract review. They get access to compensation data. It's not even $300. It's a very good checkup on your financial health of your contract to see where you should be, and then get suggestions if you need them for how to move forward with a fair offer or a renegotiation, if you will. But there's lots of data out there, MGMA, AAMC, Sullivan-Cotter. There's all different kinds of data sets. They're all lagged. So it's middle of March, third week in March, I guess, of 2023. We're still using the 2022 data set for MGMA, which is defined as the gold standard. That 2022 data set for MGMA is based on 2021 data. So 2021 happened, they captured the data in 2022, reported it out in May or June of 22. We still use that until May, June of this year, in which case we'll get the new data set, which will be based on 2022 data, 2022 year. So the years always are lagged, which is why it's not great. That's why our compensation program is great, because it's near time. So we review contracts all day. So if we did an OBGYN deal in Tampa, Florida today, and you're signing in Tampa or somewhere in a market similar, we have that data. So it's good to know what the MGMA says, because that's maybe how an employer sets, but it might not be applicable to what we're seeing near term with trends. Options create options. We do think it makes sense to get a lot of options on the table as you're evaluating pay, so we can look at different markets and the intricacies within. And again, each situation is different. So just because it says the orthopedic pay should be X dollars, it depends. If you're taking 3 calls a month or 12 calls a month, that level of work is not reflected in MGMA. It's only reflective of average salary. If you're a hospitalist, it just says the average hospitalist. It doesn't say it's per shift. It doesn't talk about people who are working 15 shifts a month and those who are working 18 to 20 shifts a month. It doesn't mention the census is 16 or the census is 23. So each situation is different. So when you guys look at data, look at it with a bunch of asterisks on it, and feel free to call us if you guys have any questions of how to interpret it. Okay. I do think it's important, if you're signing a contract this year, or if you're in a contract, every other year, raise your hand and talk about your pay with your employer. I think there's way too much on the table to let something slide and not have a good, robust conversation with the employer about your pay, about your performance every few years. I've talked to too many physicians who have gone 7, 8 years with no merit increase. When we talk to them, they say, John, I love my patients. I love the practice. I think my colleagues are great. I make a good amount of money, but they haven't had a raise, or they don't know if it's fair, or they don't know if their RVU production lines up with what their salary should be. So make sure you're raising your hand every few years, having conversations with the employer or a company like ours if we can help. But it's important to know that it's important for the employer to know that you're going to keep asking them, looking for advices and ways to get better, and of course, making sure that you're maximizing your compensation along the way. All right, more on compensation. How can we get a little bit extra in terms of creativity? Well, there might be fees for nurse practitioners or PAs and the supervision of them. We generally see anywhere from $1,000 to $2,000 per nurse practitioner per month for supervision. Sometimes we'll see a % of collections or a % of their RVUs as well. If you're a clinician who's taking time to be with the PA or nurse practitioner review chart, it might be more likely to be compensated. If you're a surgeon or someone who using a nurse practitioner or a PA makes you more efficient and smooth because they can run back to clinic and handle while you are in the OR, we generally don't see a whole lot of additional compensation because it allows you to do what you enjoy, which is procedures, and where you make more RVUs and collection. Medical directorships are another way. We generally see these paid per hour. They can be capped in terms of hours and in dollars on a monthly basis. Sometimes we'll see an annual dollar amount. If you have a medical directorship, it's important to understand the duties associated with it. The last thing I want is a defined cap on hours per month and a lot of work that you're not going to be able to get done in the cap of 10 hours, let's say. Admin time is something that you could also get paid for depending on how it's structured. Research, academic, teaching residents and fellows, we see compensation structures for those. We see partnership documents and deals where you can be an owner in an ASC or in a real estate business or receive ancillaries from the ophthalmology business for selling contacts and glasses. Or in dermatology, maybe you get a % of the cosmetics or a % of product that you sell. So there's other ways that you can earn compensation through your position. Those are just a few. There's an awful lot out there that we don't have time to get into today. Benefits are another big portion of compensation. So if you're an independent contractor, you likely don't have benefits. And so these can add up. They can be anywhere, $10, $20, $50, $70,000 per year worth of benefits. So if you have a great benefit plan, it could make up for a disappointing compensation plan. If you are an independent contractor with no benefits, obviously you should be making more than a W-2 makes in the same position with a full compensation or a full benefit package. But we usually see health, maybe some dental and some vision plans. We'll see life and disability insurance. Make sure you have these on the outside as well. We'll see vacation time offered. Typical used to be 3 to 4 weeks, a week of CME and the holidays. Now we're seeing 5 to 6 weeks of leave, plus a week of CME, plus the holidays as well. But that can be negotiated depending on the employer. Understand the CME dollar amounts, how much time you have, what funds you can use for that. And again, it can be significant when we talk about retirement contributions. Some places put 50 or 60 grand a year in retirement contributions every single year just for you. But no vesting periods, know about entry dates and all kinds of policy that they have with the retirement plans because they can be interesting. This is something that we've seen a lot in the press lately. We've given lots of talks just on this, and this is a study that was published not too terribly long ago in 2020. And just out of curiosity, I went back and I found this one. This is just a fraction of the studies, but this is in 2019 on the gender pay gap. This is another one here from 2019. Here's one about the gap is getting worse. Again, from 2019, here's another one from 2018. Here's another article from 2018, 2016. I think this one's from 2012. This is from 2004. And then I found this one, 1976. So I put this up just because it's been something that's been in the press for years. It's something that we write about. It's something that when we analyze our data at the end of the year, we still see. And there's a lot of reasons for that. But I say that not because it matters if you're a male or a female physician, if you're trained in America or overseas. I say that because everybody should be paid fairly. And it's important to understand what fair is for your particular specialty in your particular city and market with your particular story. So the group's been looking for 2 years, or the group hired for this last year. Call's going to be 1 in 3, or call's going to be 1 in 7. All that matters, and what's fair for pay should be included in that calculation. All right, compensation for an attending. Again, raise your hand every 2 to 3 years. Have data, so you go in there armed with what you know is true in terms of your production, the data that supports the salary. Understand what their position is. Hospital margins are being squeezed, okay? Medicare's getting their reimbursement cut again. And of course, have those levers to pull. We love creating lots of creative levers for you guys to pull in terms of compensation and asks, okay? And again, be creative with this stuff. We can go over how to question pay and compensation without ever asking for more money. So I can ask all these questions and none of them are, can I have more money? So should you ask for more? It depends. Maybe they say it's not negotiable. Okay, it doesn't mean that we shouldn't have a lot of questions on pay. When was the last time it changed for everybody? Will it be evaluated before I start? So we worked with doctors signing contracts for August 2023 back in November. And some places change their compensation plan every January. So what they sign may not be what they have when they show up, but it's important to know that if that's the situation, okay? Just a couple of trends in compensation, burnout. We hear a lot of talk. We are seeing it slowly addressed. We're seeing more work-life balance programs, and I think that's important. We're seeing support staff, and we're seeing that lag. That tends to hurt physician burnout, and of course, it tends to harm production in some situations. There's a lot of stuff in the press lately on non-competes. We're seeing some areas change them already, and some areas put asterisks on them. But it's important to keep up with that. We should know more here in about 2 months on non-competes and what the future is for them in the country. But my projection is that we're going to have another big fuzzy question mark, and it's going to be litigated for a long time. And you've got a lot of people at big business pushing back on them. And I think even if they ban non-competes, there'll be asterisks for certain people like high earners, physicians, and certain types of practices in certain markets. Student loan programs, we're seeing those come back. We're seeing more value in team-based care. So not just, the more you produce, the more you earn, but the more you work together, the more you all can earn. And I think that's something that we'll see in the future as well. If we continue to go through our section by section contract review, malpractice insurance is super important. And you can see we spend a lot of time on compensation because it's hyper important. You guys work really, really hard to get to that point where you've got some experience as a clinician, or you finish your training, you're signing your first opportunity. So it's important that we really spend a lot of time on that. And any questions, of course, I'm all in for them. Malpractice insurance. Now, this could be classified under a benefit depending on how the contract is set up. But there's basically two types. There's claim-based and there's occurrence-based. Now, there's also modified claims. There's all kinds of captains, there's self-insurance, there's prepaid tail, there's all kinds of slot policy, there's all kinds of sub-policy. But for the most part, we see mostly claims-based or occurrence-based. And claims-based, depending on how it's structured, typically needs to have tail insurance. So who buys the tail? It should be very clear in the agreement on if the physician's buying tail or if the employer's buying tail. If it's a claims-based policy and you need to buy your tail insurance, you really should know that. That matters on how you look at the risk in the deal and how important the compensation is. We had a gal call us a couple of years ago, and she was going to join with a private practice OBGYN group, and they weren't going to cover her tail. And when I asked her, are you going to be here a long time or just for a short time? She said, John, I haven't told them, but I'm here for a year and I'm moving on because my spouse is doing a fellowship, and then we're going to move to whatever city in whatever state and start our careers. So they weren't going to buy her tails, but she had to buy it. And she knew she was going to quit. And tail insurance for an OB physician can be very costly. So based on a salary and based on what her tail was going to run her, I suggested she didn't take the job. And so it's important to understand this. And again, depending on your frame, lots of creative ways you can negotiate tail insurance if you are required to pay it. So feel free. So again, get creative with who pays it, in what situation, at what time frame. Maybe it's shared, maybe you earn a certain percent of it over years. If it's occurrence-based, that's great because you don't need to buy tail insurance. It's baked into the policy, unless the contract says if. So sometimes a contract will say if the insurance is claims-based, the physician will buy it. And then you'll say, I'm not going to buy this. And they'll say, don't worry, we have an occurrence policy, which is true. You don't need it. But if they change it, and it says, if you have a claims policy, you'll buy it. Now you got to buy it. So again, small little nuances with words like that can really matter. It's important to have good clarification. We talked briefly on restrictive covenants earlier as far as some of the changes that may come out. We don't know. Again, we'll know something here in a few months. But there are restrictions that the employer puts on you post-termination. They could be in the form of a non-solicitation. So some states don't have non-competes. We don't see them in Massachusetts. We don't see them in California. We see them in different states in different ways. But most non-competes most restrictive covenants include a non-solicitation. So you can't solicit the employer or the patients or your colleagues, maybe even referral sources. And some restrictive covenants include a non-compete. And the non-compete needs to be defined by geography. and needs to be defined by time. So an example would be for 1 year, the physician can't work within 20 miles of a specific location. Now, states are all different, so it's important to understand the nuances. Some are county-based, some have rules with what you can and can't have, some don't have them at all, some have caps. We generally see three non-competes, 2 or 3 year non-competes in the Northeast, and 1 or 2 year non-competes everywhere else. We've seen them for a few blocks in Manhattan to 100 plus miles in some rural parts of the country. Make sure you know if it's from one location or from multiple locations. We have seen contracts that have said at any future location, which is hard because you don't know where they're going to open practices. And you could start today and they could be 2 practices. By the time you quit in 5 years, they could have 7. And if they expand it all over a metro area and it's 10 miles from each, 10 miles at first didn't seem like a big deal in Houston. But if they got one every single corner of the metro, it might be bigger than you think. So let's make sure that we understand where it's from and then negotiate it as best we can. We don't know when we'll have an update from the FTC. We think we're in the comment period right now. We think it's going to be another month and a half or so before we really know much, and maybe a long time after that before we have any actual action. Termination should be in all contracts. We see immediate termination. So this is if you cannot work, so you can't practice. Maybe you've lost your license, you get kicked off the medical staff. They can't give you malpractice insurance because you've been sued too much. You could be a sanctioned individual from Medicare and they can't get reimbursement. So if there's no reason to keep you around, they will immediately terminate you in those situations, and contracts reflect that language. There could be a for-cause termination. So you've breached a part of the contract. It says you have to be board certified and you've let it lapse, okay? It says you will take call 10 days a month and you're taking 8 calls and you're not willing to do 10. That's for cause, they could terminate you. Most of the time, physician contracts end with a no-cause termination. That's a without cause termination. So there's no reason you quit or they let you go. It's typically 60, 90, or 120 days. Sometimes we see longer, like 180 days. We see 30 days in some contracts, and that brings up a little bit of a red flag. We don't like that. All contracts have risks. So it's important to understand what you're willing to accept in terms of the risk that you'll take. Maybe it's a big salary, but the risk is your spouse might not like the area. Maybe the risk is you might have more call than you wanted to have. Let me see if I can go back to that slide. Whoops. Maybe there's a lot of compensation, but there's a big non-compete, okay? Maybe you have a low base salary, but you have a ton of vacation time, right? There could be all different reasons that you might want to accept a little bit of risk, but it's important to know your particular story and what risk is worth it for you. If we look at negotiating, we feel all contracts are negotiable, but maybe they'll tell you it's not negotiable. That doesn't mean that you shouldn't have questions, okay? So your the best alternative to a negotiated agreement. So make sure you understand what your alternatives are. If you are from, a small town in South Dakota and you're going to go back to that town no matter what, you don't have a whole lot of alternatives, right? Your best alternative to a negotiated agreement is you don't have a job, maybe. But if you've got 3 offers in Chicago, your best alternative to not taking this one is taking one of the other 2. Not a bad place to be. So it depends on what your BATNA is on how much negotiating capital you may have in a position. We like to look at there's no winners or losers. But you may get some things that you want, you may not, but there's no winners or losers. We like to think of everybody kind of playing the same game. You want to get there, they want you there. You want to help their patients, they want you to provide care to their patients. You want to make a good living, and they want to have a business that they can continue to employ physicians and give back to the community. So it's important that you look at it as it's not a winner or loser. It's how can we both win by getting what we want. There's a big difference between negotiations and clarifications. So again, are we negotiating something or just clarifying? Either way, even if you say, John, I'm happy with everything there, great. I would still ask 25 questions at least on every contract that we see, no matter how good it is. I have 25 questions on every single contract we looked at, which is, again, clarifications, which is just setting expectations to avoid any uh-ohs. I didn't understand that. Academic, hospital, employed, private practice, they all have different amounts of variability and negotiating ability. Academic contracts are actually some of the more difficult ones we look at. They tend to be more of a paragraph with not a lot of detail. They're very hard to follow, and they require a lot of due diligence and questions. Not because there's red flags in them, just because there's a lot that's left out and a lot that we feel needs to be asked. Hospital employment may be very templated. The first 10 pages might be the same for everybody. They modify Exhibit A for your schedule and Exhibit B for your pay. If you're a cardiologist or a pediatrician, everything's the same except for the 10 pages or the 2 pages at the end. Private practice, again, maybe they're more likely to negotiate and change some things. Partnerships, a lot of questions that you could ask around private practice and more due diligence, knowing that you would probably take less money upfront in a private practice that you would for an employed position or an academic one, or maybe not an academic one, depend on the situation, but there might be a better term in the future in terms of earnings. Standard agreement, if they say, look, we can't change the contract, everyone has the same thing, let's talk about a side letter. Maybe you say, look, I don't want to take call more than 10 days a month. They say, well, that's fine. We can't put that in the contract, it's standard. Or you say, I don't want to go out to the location 40 miles out of town more than once a month. Well, that's fine, but we can't put that in the contract standard, they may say. Okay, fine. Put it in a side letter. Put it on your letterhead. Say it's with our intent that you won't go to the location 40 miles away more than once a month, and you'll be capped at call 10 days a month. At least it's something. It's in writing, and we think that that counts. Resources, we're here to help with anything you need. Feel free to have CU send us over any questions that come up. We're here as a resource to you guys on behalf of the Alumni Association. There's great books out there like Chris Voss, Never Split the Difference. He has a master class that you can take on the masterclass.com website or app. It is fantastic. It talks about negotiating not only like that contract for your work and your money, but how to negotiate with your daughter who wants to go to a party and how to negotiate with your spouse, for a certain thing. So it's a fantastic book. He's an entertaining guy and lots of great experience, former FBI negotiator. We have a lot of things here. We can send these to anybody if you want to email us. We have malpractice insurance, Q&A, things about collections and independent contractors, top 10 lists and compensation questions and partnership questions. There's all kinds of things we can send you for no charge, of course, as a benefit through the Alumni Association. From the employer side of things, we always want to make sure you guys are looking at fair language. They want fair language, okay? Fair and termination, tail insurance, restrictive covenants, detailed terms versus vague language. They want incentives to work and stay employed. They want to keep you around. It's very expensive. It costs anywhere from $150,000 to $280,000 to replace a churning physician. So the last thing they want to do is have you get upset, burn out, not get paid well, and leave. It's very costly for them to replace physicians. So they want you to stick around. So find ways to work with them if that's what you want to do, is stick there. Burnout prevention, we think it's something that they should look into much more. Benefits are becoming more important. Lots of physicians now want more time off and not as much money. They want more retirement savings and something easier. They want maybe more flexible schedules. So it's important that the employers hear the physicians and the trends. And of course, having really good capital equipment and very good access to resources and staff. I hear from way too many physicians that the group is very solid, but they lack the ability to hire good MAs. Or the OR is fantastic, but the anesthesiology group has been less than present. Red flags. If there's not definitions on pay that are very clear, if there's vague statements like minimum of 40 hours or to be decided by the employer, we don't like that. If they're not transparent with certain things, if there's malpractice details that are not very clear in terms of what type of policy, the limits, and who's buying tail insurance, if termination's not fair, so maybe they could terminate you without cause, but you can't, that's important. If the restrictions, if they're not clear, or if they're just outside of market value. We talk to physicians all the time, and I hear this too much, is that they wish they talked to us 3 years ago. So whether talking with us through an educational session like this, share our information with your colleagues, and we're happy to give more of these talks, or give us a call. We have a free 15-minute consult on our website at contractdiagnostics.com. You guys can go to and set up a free 15-minute call. We don't call you afterwards and bother you. We don't pitch you crap. We just are here to help and consult with anything that you need. So to that end, my name is John. My email is here. You can email info@contractdiagnostics if you want. If you call the 888 number, Miss Jan, our director of operations, will pick up the phone. She is fun and cool and very knowledgeable as well, and able to answer lots of questions. But with that end, I'll turn over to Dr. Parr. If we have questions, I can answer them. If that's for a later time, since you guys have a busy day, I will say thank you in advance for the time. I have a great time doing these, and we'll be here to help with anything that you guys need.
Thanks so much, John. We do have some questions in the chat box. The first one is, what sort of data should we be putting together when preparing conversations for potential raises?
What was it? What details?
Yeah, what sort of data should we be putting together when we prepare for these conversations?
Yeah. So I think it's important, no different than if I go in for a physical, right? I think it's important to kind of do like a state of the health, right? So make sure you know everything, right? You have how much vacation time? What percent of your CME dollars have you used in the last 3 years? What's your production? If it's RVUs, if it's, maybe they don't manage, maybe you don't even get RVU data, but maybe you know patients per day. Maybe you look at, the average hours you spend on admin time. Maybe you just take notes on, we're lacking an ultrasound machine in a clinic, or, I wish we had another MA or an extra room to put patients in. I think it's important to put all that down, know exactly what you earn, know what they put into your retirement plan and compensation plan, because they will likely use that as your total compensation, as your TCC, if you call it, their calculation. I think it's important to know all of those things, but it's one thing to know them. Again, if I know my cholesterol's 100, that's fine, but is that good or bad? And that's where you need to know, okay, now I need information behind that to say, is this good or bad? And then what do I do about it? So let's find out, okay, what's my lab value? My cholesterol's 100, if you will, right? Okay, is that good or bad? Well, if it's HDL, it's good. If it's LDL, maybe it's not very good. And then what do I do about it? Well, here's my prescription, right? I can take a pill, I can do exercise or change my diet or do genetic testing. So there's lots of things that we can look at in terms of that algorithm. But I think first off, you get all the data and information together. You know what the data shows, so get MGMA, get data like ours, internal data, real-time data, and then have a plan going into that meeting, so you don't just sit down and say, hi, here's my information. You need to have a very, very specific plan, just like when you talk to a patient about their problem for the day.
Awesome. So much. There's a couple more questions, and it looks like we have a few minutes. Should all contracts be reviewed by a professional or lawyer, and what are the costs for these sorts of reviews?
So I am not a great salesman, and I'm biased because this is what I've done for 12 years. With a caveat, I think that all physician contracts should be reviewed by an expert, somebody who reviews a lot of contracts. Not just a lawyer. I hear from way too many people, I have my contract looked at by a lawyer, and the lawyer who does divorces all day doesn't understand what an RVU is, or doesn't understand. If they know what an RVU is, they don't know what a cardiologist should get paid in Boulder, or a private practice pediatrician in Aurora. So it's important to understand, who you're gonna have do this. Should all contracts be reviewed? I never want to say all, because that's just too global. There are some large practices in California that are popular and well known that I've seen their contracts enough. I don't feel that you guys need to have certain contracts like that reviewed. They're 5 pages. They're very simple. They're very clear. And if someone sends one of those to us, I typically refund their money and hop on the phone with them for 15 minutes for no charge. Academic contracts, I think most of them should be reviewed. Do you need to spend a ton of money having someone negotiate it for you and do all the back and forth? I don't. I think a cheaper basic review would be fine on that. I don't know what other people charge. Our packages start at $250 is our cheapest package. We have our kind of real full review is $440, and then our most expensive is $1,900. That's a full negotiation, which makes sense in a lot of situations, and not a lot of situations it doesn't, which is why we encourage you guys to call us so we can guide you on which product may fit best for you, so you're not spending too much or too little based on what you need. And the packages that we have at Contract Diagnostics, just so everybody knows, 12 years ago, we had focus groups with residents and fellows and attendees that help us set the company up. And one of the things that they asked for was what we called flex pay. They said they don't want to pay all of it up front. They want to pay a little bit here and there. And we said, how about we do flex pay? So I know our most popular plan is middle 700s, and you can spend $200 now, and a credit card is automatically charged for 5 months at $100 or something. So that's one of the things that we do. But overall, it's probably one of the better investments that a physician could make earlier in their career to make sure that they start off on the right foot and have a good understanding of the contract. Knowing that we don't just review it, we actually coach you through it. So you it's almost like a one-on-one course on contracts every time you go to one of our packages. But yes, I do think that most all contracts, 97% or so, should be reviewed by somebody who really, really understands contracts and dedicates a big portion of their practice to it.
Awesome. We've got a couple more. So there's a question about signing and relocation bonuses. When are they typically paid out, and are there other stipulations that people should be paying attention to?
Yes. So they used to be paid as signing bonuses. So you sign a contract and they send the money. Now we're seeing commencement bonuses. So you sign and you get it 30 days after you start working. They roll through payroll, meaning they take out 401k and taxes and everything else. So I think that could be negotiable depending on the opportunity. We see signing bonuses in about 72% of contracts. They vary from $1,000 to $280,000 depending on the situation. They may or may not be accompanied by a relocation dollar amount. They're most typically tied to a promissory note or a repayment provision, meaning if you terminate the position or get fired, or who knows, it depends on how it's structured, within a certain time frame, you would have to pay that back. That's generally between 1 year and 5 years. Again, it's all a function of the dollar amount. For a larger amount, they might be more of a repayment provision. It's important that physicians understand the taxes on those, when they pay taxes, if it's now, if it's as it's forgiven. And then, of course, if they need to repay anything, what amount they need to repay, if interest accrues from day one, if it's forgiven over time, if it's forgiven all or none, or if it's prorated. Yeah, we generally see signing bonuses, and I think those could be very beneficial. But I realize that maybe you don't need one when you're making a physician salary. You need it when you sign your contract and have those transition expenses. So I think they should be negotiated. To be signing bonus means a signing bonus. You sign and they send.
Yeah, especially if your kind of tax bracket as a resident or a fellow is a lot lower than you expect it to be.
Exactly.
And then so there's a question about how to address the gender pay gap. Is there any approach that should be used other than knowing there exists, that a gap exists, and the general expected pay for a specific field and location?
How to handle it. We talked about raising our hand every few years. And I think this is something that historically male physicians have done much better than female physicians to advocate for themselves, to receive, raises and ask for more. And I think that that's something that every physician should do, whether you're a male physician or a female physician. I think everybody should raise their hand every other year. I was talking to a physician today through that compensation product that we have. And I said, sometimes a squeaky, he said, well, Jon, and I actually told him, I think they're offering a pretty good deal. And he said, so should I even say anything or just sign? And I said, no, I would say something, because it's good to be on record that you're one of the people that's going to ask every couple of years, hey, what's going on with that? And I think it's good. So if they're looking at, I hate to say what they could get away with, because I don't want to sound like the employers are bad. They don't. They want what's best for you guys. But if they're looking at who do we take care of this year, I want them to think of, Dr. Parr is always the one that's raise your hand and say, hey, can we have a conversation about my efficiencies and my production? What can I do to get better? And of course, what can we do to maximize my compensation? So I think the squeaky wheel gets the grease. And I think it's a way that you can be, in a respectful way, the squeaky wheel by raising your hand every other year and having a conversation, even if nothing comes out of it. I think that's one of many ways to adjust the pay gap. But of course, just understanding your fair value as well and knowing what your production looks like compared to all of your peers.
Great. And we'll do one more question in the chat. How much extra pay should you expect if you don't need loan repayment and that's a benefit of the job, or like an advertised benefit of the job?
And you don't need loan repayment, right? Okay, so this is,
if you're lucky enough to not have loans.
Yeah, so this is challenging, because if you're lucky enough to not have loans, as you say, sometimes we've seen contracts that say that a physician gets $100,000 for loans, and our client won't have loans. And we'll say, look, so how can we reallocate this money? The employer will say, you can't, it's a loan program. So know that that's a possibility. Now, could we get creative with it? Maybe. Some people have private loans. So maybe you took out a loan from a private investor or from a family member. You typically can't use student loan reimbursement programs for private loans. So if you have that, offered and you don't have loans, I think it's really good to have a bunch of ideas of how to reallocate it. Could it be reallocated in the form of a lump signing bonus? Could it be an increased compensation amount per year over 3 years? Could it be maybe it's not like, maybe it's an increased vacation amount over the 3 years since you don't have the loans to take advantage of. Maybe there's another way that we could find ways to make up for it, but that's something that I feel if an employer has allocated, let's say they've allocated, $500,000 for 2 years for a position, salary of 200, signing bonus of 50, and a relocate and a student loan of 50. Okay, my assumption should be like they have 500,000 to allocate to that position for 2 years. If it's salary, if it's signing bonus, if you want $100,000 salary and the rest is signing bonus, it's the same to them as long as they amortize it over and show its fair market value. So I think that as a physician advocate, of course, I think that it should be easy for a group to do those things. But we always haven't had success with that. We have had some groups say, no, we can't do that. This is a student loan program. So I think it's good to go in with options and again, be creative on the negotiating table, but know that they may or may not succumb or agree to your request.
Right. Wonderful. Thank you. So everyone that's attending, if you think of a question or your question wasn't answered, you'll have the opportunity to submit any further questions for Jon in the post-event email that you'll receive soon. Thanks to Jon for joining us today and sharing his insights regarding this really important topic. I mean, we've all worked very hard to get to where we are. Now let's try to get compensated for that. And to the house staff, thanks for spending the last hour with us. And we hope this has been helpful for you. This is a topic that couldn't be more relevant to physicians at all stages of their careers. And we're grateful to Jon and Contract Negotiations to help educate physicians in this area. If you have any colleagues or friends that you feel would benefit from this presentation, the recording will be uploaded to our CU Anschutz alumni YouTube channel very soon. We'll also send an email with a link to the recording to all who registered, as well as information about upcoming events. A couple of things that we wanted to tell you about. We're excited to invite you to the CU Medical Alumni Association night at the Opera featuring Turnida on Tuesday, May 9th. There'll be a reception with hors d'oeuvres, desserts, beverages, and we're offering Housestaff discounted tickets to the opera, and you'll receive your discount code in the post-event email for this event. Also, please join us for lunch on campus on Friday, April 9th from 12 to 1:30 in the Krugman Conference Center. The CU School of Medicine and the Medical Alumni Association would like to invite you to join lunch, network with current medical students, and food will be provided. So the registration link will be put in the chat here. It looks like it's in there now, so please register and get free lunch. And lastly, be on the lookout for our newly created quarterly newsletter, Housestaff Connections, that's designed specifically for our residents and fellows to keep you informed and connected to the CU Medical Alumni Association. Thank you for joining us and have a great rest of your week.